So I'll try to finish it as fast as possible. So we'll have a case-based discussion on fertility preservation, and I think it's already 1, and I'm between your lunch and uh, the scientific session. So we all know that premature ovarian failure, reduced sperm count, and infertility are collateral effects seen in oncological therapy. So I would like to ask as to what are the different reproductive parameters which are affected by cancer therapy?
Go ahead, ma'am. You can speak.
Yeah, you're asking about the reproductive parameters affected. Okay, the most important thing is when you're treating a young patient, the oncologist is definitely concerned about the reproductive outcome of the patient. That was not there in the past. Probably Jayaprakash sir would be a better person to comment, but this oncological, we used to concentrate definitely on the oncological outcome. But now with the better oncological outcomes, the patients are living, we are concerned about the reproductive outcomes also. So we do refer them to the infertility specialists, not just the patients who are not conceived, but young patients who are coming to cancer treatment. We do send them for assessment of their reproductive factors, and probably you as a reproductive specialist would be better.
I think she's already got it there. What we worry about in females is the ovarian reserve, in males the sperm counts. Then of course we have sexual dysfunction, which becomes a major part, especially when radiotherapy is done or even surgical procedures in the male, and uterine dysfunction. So majorly these are the important areas that we have to worry about when a patient goes for onco treatment.
So is it only the treatment that affects, or the cancer also affects fertility?
Both affect the fertility, cancer as well as the treatment. Side effects are there, and also mainly the tumors affecting the genital organs will affect radiation, chemotherapy.
So which are the cancers which affect fertility apart from the treatment?
Pardon?
Which are the cancers which affect fertility?
Yeah, we always discuss with the patients and the relatives regarding the effect of treatment, side effects of the.
No, which cancer?
Yeah, when you're talking about a female, when you have a cancer in the ovary or the uterus, definitely that's going to affect the fertility. When ovarian cancer, you always have the option in early cancers for doing an ovarian preservation. And uterine cancers also, in the endometrial cancers in early stages, we have the option of hormone treatment and fertility preservation.
Yeah, so basically in the female it's a breast cancer where you have the BRCA mutation, where you have decreased ovarian reserve, and lymphomas. And in the males basically it is more of lymphomas, leukemias, and the testicular tumor itself, which is going to affect fertility. So we have, when we go to the first case of endometrial cancer, which we know is the 6th most commonly diagnosed cancer, and its prevalence is rising in younger women, especially in those who have polycystic ovarian syndrome. And basically, normally what we would do is a hysterectomy with bilateral salpingo-oophorectomy, and fertility sparing treatment can be considered in grade 1 stage 1A disease, and hysteroscopic guided endometrial biopsy are preferred for confirming the diagnosis. So this was a patient who was 32-year-old who presented with subfertility for 2.5 years. She was diabetic for 3 months. She had subclinical hypothyroidism, and she had anemia due to irregular cycles, for which blood transfusion was given. And if you look at her hormonal profile, we can see that she has polycystic ovarian syndrome because her AMH is 15.14. The semen analysis was normal, and she had undergone several cycles of ovulation induction with clomiphene citrate and letrozole, but had not ovulated with any of them, and so she was referred to us. So when we saw her BMI was quite high, it was 30, her waist circumference also was high, she had both hirsutism and acne, and you can see she had severe PCOS with more follicles, and then well, basically HSG was done, and that showed an uterine polyp, though both the tubes also were not very healthy. Her lipid profile also was abnormal. So basically, we had told her for lifestyle modification, and we reviewed with the endocrinologist for diabetes mellitus and hypothyroidism. We advised a hysteroscopy in view of the polyp, but she wanted to try a cycle of IUI because she had only gone for time. She had gone for ovulation induction, but had not ovulated. So we did give gonadotrophins, and we did an IUI, but basically she did not conceive. So when we did a hysteroscopy and we sent the curettage, we found that it was endometrioid carcinoma, grade 2, and MRI was done, which was normal. So she was referred to an oncosurgeon, and he evaluated and started her on Megestrol, 160 milligrams, which was given for 3 months. So what would you do next in this patient? Whether you would go for fertility preservation, or would you wait till there's regression and then treat the fertility?
So regarding this patient, I think the grade was given us, we go grade 2 to 3. So that is not an indication for fertility preservation. Only grade 1 disease, no myometrial infiltration is the ideal patient for fertility preservation with a Megestrol or LNG IUCD. And one more thing is, if you want to keep the patient for fertility preservation, that patient's fertility should be assessed before. If the patient is not going to be pregnant even after the treatment. So in this patient, I think her ovarian reserve is less, and so many things which will lead on to infertility. If that fertility part is not going to be corrected, there is no role for fertility preservation. And especially if we go 2 to 3 means this patient should go for a hysterectomy.
Yeah,
No
but she
role
was
for-
referred to a gynec oncologist itself, and he said that you could probably treat her with Megestrol because we have not treated her. But would you not,
Probably
even if you're
grade
going to
2.
do a definitive treatment, would you like to go for fertility preservation? Because you can still go for fertility preservation, you can do a hysterectomy, and then probably the patient can go for surrogacy. So would you advise such a thing?
So grade 2, you can do for after a further discussion. Not one person can decide. We might have a tumor board and no myometrial invasion. If there is more than 1 to 2 mm myometrial invasion, we are not doing it because it's supposed to fail. Another thing for her, if it is grade 2, if at all we are going, we can ask her to lose some weight. That may help her with this treatment as well. If she does a bariatric surgery or something along with that, that will help her with the treatment as well. Or else, and then you can, after 3 months, definitely you have to evaluate. If she is not showing a response or she is progressing, then there is, if she is progressing, definitely you stop it there. If she is showing some response, at least 6 months you can wait. If it is grade 2, without myometrial invasion.
And may I add, the treatment is inadequate. You can give up to 320 milligram Megestrol,
Yeah, that is
and you can complement with the LNG IUCD also. So the treatment decision, probably you needed a better assessment at that time. It's not just the endometrial biopsy grade, you also have to know the molecular testing. MSI and P53 mutants are contraindications for fertility preservation. So you needed a proper assessment at that point. And now at the point where you have started treatment, you're given a subadequate dose. If the patient still insists, still ready to take the risk, I would say that she can continue with a proper dose of 320 milligram per day with the LNG IUCD, and maximum we can wait up to another 3 months and then call it a day if it's still there.
Usually we
I
advise
think,
only grade 1 patients with the myometrial invasion.
No, I
Grade
think-
2,
There's
we
no,
always go
yeah,
with
there's no
molecular
myometrial invasion in this
Yeah.
patient.
Yeah, no, I think the
Molecular
point
profiling.
she's trying to make, and we are actually talking at cross purposes, you are looking at fertility sparing treatment,
Treat.
whereas what we are talking about is for future fertility preservation, which would be in the form of oocyte freezing, which can very easily be done before she gets her
Or
uterus
embryo
out.
freezing also can be done because,
Whatever, oocyte.
yeah.
So I think
That can be done at any point. Here we want the uterus, and she wants to conceive with her own uterus. So that's the option first. Like Sir said, we should give a complete chance for that. So long the patient is willing to accept the risk. We will tell her that hysterectomy is the standard treatment for any cancer endometrium. If she is willing to accept the risk of 70% response and 40% chance of recurrence of endometrial cancer, she can go for this hormonal treatment, which should be at a proper dose with proper assessment at 3rd month. And if it is still endometrial grade 1, we should call it a day, but if patient insists, we can go for
So if
another
you're
3
going
months.
for medical treatment, when would you say that it has failed?
6 months.
6 months.
Yeah.
But the literature basically says
No,
that-
up to 6 months if there is no response at all. But if there is partial response, you can give up to 15 months to say that it is failed. If it is partially responding, you can continue with the treatment. If at 15 months, again, it is not responded complete, means it is failed and you have to go for a definitive surgery.
And what is the risk of recurrence?
It's around 40% can recur.
So basically, we repeated after 4 months, and it was slightly better. It was well differentiated, and so she was advised again by the oncosurgeon to continue for another 45 days, and we did the MRI, and basically it was limited only to the junctional zone, and it was not involving the myometrium. And then a repeat hysteroscopy showed that there was no disease; it was only metaplasia. So in
Madam,
these
can
cases,
I add something? It should never be an oncosurgeon, it should be a gynae person.
yeah, he was a gynec oncosurgeon.
Okay.
He was not a normal oncosurgeon, he was a gynec oncosurgeon. So should ER and PR status be done once diagnosed for this patient? Is it going to be helpful?
No, we usually do ERPR once diagnosed, and also we go for a molecular profiling. If it is bone mutant, survival is almost 100%, and we can be without much problem. But if there is a DMMR type also, prognosis is better. Whereas it comes with the
Can I
common
add?
type, usually ERPR is more common in the common type, like a non-specific molecular profile type.
Can I add one
Whereas
thing?
P53 mutation is very aggressive.
Yeah, so
Definitely
that's what, I mean, if she is negative for her PR, then still, we can give the progesterone therapy.
Negative ERPR is not a contraindication for hormonal treatment.
Pardon?
Not a contraindication.
The?
90% of the endometrioid carcinoma will be ERPR positive, and all patients will have
No,
IHC
if it is
ERPR.
negative, then it could be
Negative
a-
is not a
Yeah,
contraindication.
that's what, yeah. So when would you allow pregnancy, and whether you would like to go for spontaneous, or would you advise an ERT in this patient?
Yeah, we continue the hormonal treatment to 6 to 9 months. We usually go for 9 months. Take a repeat endometrial sample at the end of 9 months, and make sure that the endometrium is reverted back to normal. And then you advise the patient to go for a conception as early as possible. So we advise ART.
Yeah. Nalini, would you advise her a spontaneous pregnancy, or would you go for ART?
So it's a dilemma because these patients, the recurrence rate is very high, and it is between 12 to 24 months that the recurrences occur. So if all other fertility parameters are very good, there's nothing else, maybe 3 months is what you can give her, and otherwise then move on to ART, because she is bound to require definitive treatment, and then that will become a
Wasn't she already getting problems with conceiving? So why wait?
Yeah, I think ART would
No,
be.
that's what I said, that if a person is where the fertility is very good, it's in the sense not fertility, but all parameters of, if there is an infertility.
In our this thing we say the moment we get 2 negatives, next month let her do. That is what we do. Because we are doing this only for fertility. After fertility is done, we would like to go
Yeah,
ahead
so
and
you'll
do
go
a
for a
full-
definitive
yeah.
treatment.
Better
Yeah.
to decrease the interval between conception and treatment.
And what if she wants a second child, then what would you advise her?
Definitely, if she wants a second child, she is at risk. So
She?
is at risk in between. So if she wants an interval between the 2 children, we will give some hormones, like a Mirena would be better, and keep her under follow-up. She should be every 3 to 6 months, she'll be under follow-up. Then she can again go for, if she is finding it difficult to conceive, again the help can be
Can you
taken.
preserve the ovaries and remove only the uterus in this patient?
Yes, of course, depends on age. If any patient less than 45 years with a grade 1 or 2 endometrial cancer, we do preserve the ovaries. And it's not just for the fertility sake, it's for the hormonal sake also. we do preserve the ovaries, but and again we make sure that molecular study has been done on the endometrial sample, make sure that she is MSI proficient. For
So would
MMR
you-
deficient patients, we don't because it's associated with Lynch syndrome. So we make sure that she is MMR proficient in a molecular study.
Yeah. So would you like to do a frozen biopsy when you're doing a hysterectomy?
Never, never. We
to
do
see the-
depend on the
because there
endometrial
are
biopsy.
chances that the ovaries may be affected na, in endometrial carcinoma.
Frozen of what? The ovaries are not, yeah. You can't take the ovary and we do keep the ovaries. That applies not just to this patient. Any patient less than 45, we do keep the ovaries.
So basically, when would you advise alternative? That is, whether if she wants to go for ovarian, I mean, either oocyte or embryo cryopreservation, when would you advise her? Like, we are going to give her medical therapy, but then probably you would want to also to do a
In a
oocyte.
patient who is progressing during medical treatment, when you're planning a removal of ovary for whatever reason, you advise oocyte cryopreservation. If the patient has a partner, definitely embryo.
So would you like to go for OTC, that is ovarian tissue cryopreservation in this patient?
It's controversial really because there's a high risk of secondaries being there in the ovaries. You can't freeze, but when you are going to put it back, it is better to do it in a heterotropic under the skin or something, do an IVF and then remove it. So there are still a lot of controversies in that area till you can really identify that the tissue you're putting back doesn't carry any cancer cells. Till that time, there is always a risk.
And when you're going for stimulation, there's any particular protocol which you would use?
I would prefer to use the progesterone, the PPOS protocol, because progesterone is protective to the uterus. So you can use that. You can also leave the LNG IUD in place and use that as a down regulator and carry on with your stimulation, because that has been seen to reduce the recurrence rate in these patients.
So would you like to add letrozole when you're stimulating to keep the E2 levels low?
I'm not a big fan of letrozole, but yes, you can. It will keep the estrogen low, but I don't like letrozole, so I don't use it because it is associated with abnormal oocyte morphology, so I don't use that.
So how would you prepare this patient for FET? Like, I mean, if they're all not ART.
No, they're not ART.
We
Okay.
are all
Onco people. Okay, so the ideal way for these people is to have the transfer in a natural ovulatory cycle. So you expose them minimal to any extra hormones. If in PCO patients who are anovulatory, you can give an ovulation induction agent like letrozole. That will help there. Try to get them to ovulate. Of course, if nothing works, then you will have to give estrogen and progesterone to estrogen to build the lining and then progesterone for secretory change. But you should try as early as after 8 weeks when placenta starts forming, you should try to reduce.
So basically, once she was negative, we did simulate her patient. We added letrozole, and this was done quite some time back, so I didn't use the PPOS protocol in this patient. But even because she was PCOS, severe PCOS, we had kept her dose low, but she didn't respond, and therefore we added HMG then to this patient. And basically, we had given her a trigger almost on day 21 because she was not responding. We had 12 oocytes, all of them were M2, and we did ICSI, but we can see that the quality of the oocytes was not good, and then only we had 2 blastocysts, they were also of grade 2, and basically she did not conceive, and she then underwent a definitive treatment after 18 months after ART, and she was not ready to preserve her embryos or oocytes, and basically probably she was aware that her oocyte quality was not good. Going to borderline ovarian tumors, we know that they are almost asymptomatic about 16 to 30% of the times. They have non-specific symptoms like pelvic pain, abdominal distension, and dyspareunia, and they are basically discovered incidentally, and a definitive diagnosis is only on histopath, and that is only on post-surgery. They have a high survival rate, Though the surgical treatment is hysterectomy with bilateral salpingo-oophorectomy, fertility sparing surgeries can be done, and once they complete the family, we can go for a radical treatment. And if we are going to do a cystectomy, we must realize that we are going to decrease the ovarian reserve, and the spontaneous pregnancy rate in the fertile group is almost about 54% after a fertility sparing surgery, and the risk of recurrence is 13 years. So this was a case, she was 24 years unmarried, and ultrasound showed a clear cyst in the right ovary, 6 centimeters, and did not resolve with the oral contraceptive pills. CA125 was normal. A laparoscopic cystectomy was performed, and the histopath was seen as borderline ovarian tumor. So is MRI mandatory in all patients who have a ovarian cyst? Because I think we don't do an MRI in all the patients.
So I think,
Dr. Neetu had an excellent talk in Hall B about
So you should then say, ma'am.
yeah. Same topic, borderline. She gave us an excellent lecture.
I think a good ultrasound with iota next model will be better. You need not go for MRI for all patients. Iota next model is better to pick up because solid area, papillary excrescence, which all will be taken by especially by the transvaginal sonography. It is more sensitive to find out the papillary excrescence and solid area. So MRI is not needed in all cases.
As I was saying, it is not the mode, USG or MRI, it is the eyes which look at it. So if you have a good sonologist, he would do a better job if you have a wrong MRI person.
Would you advise? Yeah.
I discussed my surgical colleagues in the KIMS Cancer Center. They all agree for they want MRI before doing surgery.
So what
No,
we are
but
thinking
if she
is,
goes to a normal gynecologist, basically
Yeah.
it's a histopathological diagnosis. So I don't think the gynecologist really do an MRI before doing.
That's
You
what
do,
one- once they
Jayakrishan?
reach an
MRI in all
oncological-
patients with an ovarian cyst? All patients you know. I mean,
it's up
we
to
never-
the person. Once they reach an onco center, we go for MRI or CT, whatever. But before that, I mean, it's actually not needed. An ultrasound showing MRI is not going to add
solid
much.
area. If there is a solid area, this you were telling it's a clear cyst.
Yeah.
So they didn't ring a bell probably. If there is a solid area, if there are multiple septae,
Yeah,
which
probably.
rings a bell, there is some vascular change or Doppler changes, then maybe you will be, it's very rare that a clear cyst will turn up.
Yeah, and the answer would be like anything suspicious in ultrasound, you can confirm with an MRI if you think so. It's not mandatory.
And what about the tumor markers?
Not going to help you. But it's routinely done, but it's not going to help you in your surgical plan or treatment wise.
50% of the stage 1 and 2 will have a normal CA125. Doesn't mean it's normal.
And any other tumor markers would you like to do?
If it is a mucinous, CEA can be elevated, but CEA can be elevated in other for other reasons also. And another thing is, we are not sure of the histopathology until you really have it. If CEA is elevated, you might have to go for evaluation of the GI. So definitely we do CA125 CEA, and if the person is less than 40 years, we do. If it's a solid tumor, we do other tumor markers as well.
What are the other tumor?
Alpha fetoprotein, HCG.
Johnson.
What about
yeah.
CA19.9 and HERS4?
CA99 is a marker for mucinous tumors and for pancreatic cancers. Practically, it's not going to help you, so it's going
so we
to
would not-
add to your confusion. So the maximum things to be done is CA125 and CEA. And if I can comment on the sentence before last, we never do PET, not even for a malignant
Yeah, so
ovarian
normally
mass.
we also, if it's just a simple cyst, we won't do a frozen section, I think.
Any ovarian mass needs a frozen assessment, yeah. But never PET. Practically, we never go for a PET CT. It's always intraoperative frozen section, anything suspicious.
So basically, what about the surgical staging?
The basic principle of surgery is remove the tumor without spill
Because
if you're
suppose
suspecting.
because you have not diagnosed it when you
Yeah,
have done the
you are
cystectomy,
suspecting-
so you get the histopath diagnosis, so would you operate and do a surgical staging?
Yeah, you are suspecting a borderline means there is some solid area, something, it can either be a borderline or malignant. Only a histopathology after your surgery is going to confirm your diagnosis. So the basic principle of surgery is remove the tumor without spill and do a peritoneal staging with biopsies from pelvic, peritoneum, subdiaphragmatic and paracolic vata peritoneum with the omental biopsy. That is the basic surgery. No dissection is not done.
If you were asking if you had a borderline after
Yeah.
surgery and what to do, you
Yeah.
got a report.
Yes.
The thing is that borderline is a very difficult diagnosis for a pathologist. Usually they are big tumors and there could be a small area of invasion which might be missed. So the ideal thing would be having an expert pathologist look at it. So if it is better to get a gynae-onco opinion, then what we do is we get a slide and block reviewed. Possibly, if possible, the whole specimen. We have a gynae-oncopathologist who will take a look at it. And then we redo the imaging. If there are images from before, we ask our radiologist to take a look at it again and we redo the imaging. If we don't find any disease, we put it in a tumor board and we come into a consensus and possibly, mostly, we keep them under follow-up. But if there is a residual disease and we are suspicious, we go in and try to do a full staging.
So what criteria would you keep in mind basically before you're advising for fertility sparing surgery?
First, they should want a fertility sparing surgery. Then the thing is, borderline, we start with an ovarian mass. We don't know if it's borderline, benign or malignant. That is what madam was trying to say. We always start with a staging laparotomy. The plan is always frozen and proceed. So we do a frozen. If it is a very clear cyst, very mild suspicion, if it is a serous BOT, you can do a unilateral USO or a cystectomy. If it is a mucinous, there is no role for cystectomy. You have to remove it as a whole. Mucinous tumors are usually huge and they have variable areas. So there might be a small 5 mm area of invasion which might make it as mucinous carcinoma. That is the same reason frozen is also difficult for them. So definitely for mucinous, you have to remove the whole tumor. Serous, you can do a cystectomy. If bilateral, you can do bilateral cystectomies or one USO and the other cystectomy. So that is how and if possible, you can have a fertility consultation before surgery. Usually they can, if it is a dire situation, they can do a 2-week stimulation and let the oocytes. Like that's what we do usually.
Can I add on to whatever Dr. Neetu has said? The intention of surgery for any patient who desires fertility should be fertility sparing, because you get to know the histology only after surgery. So the first surgery should be fertility sparing. And if it is a unilateral tumor, you remove the entire ovary. It should be unilateral salpingo-oophorectomy. Even with peritoneal implants, non-invasive implants in a borderline tumor, you can still do fertility sparing. So your first surgery should always be fertility sparing surgery.
Yeah. So would you advise spontaneous conception or would you like to go for iatrogamy?
People, unless you've been treating them for infertility, generally their fertility is quite fine. And you can definitely allow them to try for spontaneous pregnancy if all other parameters are normal. If there is a low AMH or any other male factor or a tubal factor, then maybe it is better to preserve the oocytes or embryos as the case may be, and then then you can do an embryo transfer, because you're looking for quick conception. You're not looking to delay conception in these patients, because ultimately at some point, if they have a recurrence, you'll have to take out everything.
So would you discuss at that stage fertility preservation and the various techniques what you could offer to her?
Well, if the patient is referred to me, definitely we'll discuss, and then post-surgery she can take a call as to what she wants to do, whether she wants to do oocyte freezing or embryo freezing, or maybe just go for IVF with the transfer straight away after her surgery, have the IVF after surgery, and do the transfer, because as we said that if she's married and looking for fertility, then just freezing that doesn't make any sense.
Yeah, so the spontaneous pregnancy rates are good enough, so we can allow them to try to conceive spontaneously and almost for 3 months. So this was another patient who was 29 years, who was married, and the MRI showed a solid cystic lesion in the left epinexia. There was no other lesions or lymph nodes, and all the tumor markers were within normal limits. X-ray also was normal. So laparotomy with surgical staging with left salpingoophorectomy uh, uh, was done, and multiple peritoneal biopsies plus lymph node dissection was done with appendicectomy. The intra of the tumor was had a bossulated appearance. The capsule was intact, no lymph node enlargements, right tube and ovary were normal. And the histopath showed atypical proliferative serous tumor. It was stage 1A. The ovarian reserve pre-op was AMH was 2.48, and post-op AMH had reduced to 0.75. So the patient really does not want a family for 2 years. So what would you advise her regarding her future fertility?
I want to tell you one thing. How can we say it is stage 1A? Did she have a peritoneal staging?
Pardon?
She had everything. She had laparotomy with staging. No, the second. The following year.
Okay.
Yeah. So what would you tell her regarding her future fertility? Because her AMH had reduced to 0.75.
We are concerned about a risk of recurrence also. She is a borderline tumor treated by unilateral salpingoophorectomy. If you ask me, the risk of recurrence after this, she's got around 10% risk of recurrence of the borderline tumor and can happen within 2 years. So if she wants to wait for 2 years, probably I'll send her to Dr. Nal.
Yeah.
In the sense that I think that she should preserve her eggs or embryos because 2 years at 0.75
Yeah, down.
ART may not.
Mike.
So because her AMH is already very low, so it is better that she preserves some embryos so that if she doesn't conceive after 2 years spontaneously and she hasn't had any kind of a recurrence, then at least she can use those embryos. But after 2 years, the reserve may be so low that we'll get nothing on ART. So it's better to at least preserve some.
So would you like to do a
role
dual
for
stimulation in this
suppression?
patient?
Sorry?
Dual stimulation to get more number of embryos?
We could try that, yeah, depending on what you get in the first.
After that, will you suppress the ovaries or something?
Why will we suppress the ovaries? Do you want to suppress the ovaries from onco perspective?
No, I am just asking,
No,
like,
that's what I said.
preserve fertility.
No. We just do a simple stimulation and, see how many oocytes you get. If you get less, you can do a second cooling cycle.
Stimulation.
And in this case, it really doesn't matter because we are not worried. We need not do a dual stim. We can even go for a second stimulation after a month or 2 months whenever she's feeling comfortable. There's no urgency to it. And preserve whatever we have.
So how will, how would you follow up this patient? You've done the fertility preservation basically because her AMH is low, but how would you follow up this patient?
So the follow-up of the patient after fertility preservation should be once in CA ovary, also once in 3 months for 2 years, once in 6 months for next 3 years, and yearly. And when fertility preservation is done, to find out the recurrence, we have to go for imaging at every visit. Clinical examination plus imaging is needed because if we are going to do a cystectomy, the chance of recurrence is around 30%. So if ovarectomy it is 15%, now it is 30% chance of recurrence. So every visit you have to go for an ultrasound, transvaginal ultrasound along with the clinical examination.
So MRI is not required? And
No
ultrasound
MRI,
is,
ultrasound.
enough for that. So we'll just go to this third case. She's a case of chronic myeloid leukemia, and we know that it can reduce the AMH levels, and today what we use is the tyrosine kinase inhibitors in these patients. So she was a doctor basically, a 34-year who was married for 6 years, and she had a spontaneous conception in 2017, which was terminated at 19 weeks of gestation because the baby had a congenital anomaly, and and then basically she was diagnosed post that with chronic myeloid leukemia, and she was on tyrosine kinase inhibitors for 3 years, and currently she's in remission since November 22. So before she came to me, she had undergone IVF outside, and they had done a freeze-all cycle with PGT. They had total 7 embryos, and 3 euploid embryos were frozen. 2 had aneuploidy, 1 was mosaic, and 1 was negative for the DNA amplification. She had attempted 3 cycles of FET, but they had not done the embryo transfer because she had a thin endometrium. So they had done all the various gene sequencing in both the husband as well as the wife. So what is the follow-up, what you do in the treatment-free period? Because now we've stopped the tyrosine kinase inhibitors and she's trying to conceive.
So for this patient, I think she was in remission for around 3 years. That is when we had stopped the tyrosine kinase inhibitors. So ideally for TFR, we would prefer it to be at least 4 to 5 years of deep molecular remission. So if the patient has achieved deep molecular remission for 4 to 5 years, then we can definitely go for TFR so that she can plan a pregnancy accordingly. The usual follow-up is when we start the TFR, then so basically the CML, everything is related, or all the assessment is based on the BCR, ABL, PCR. So what we do is once the patient has been gone to TFR, then once monthly we check the BCR, ABL, whether the ratios are rising. If in the initial 6 months they are not rising, then we can slowly increase the delay the frequency of checking. We can do it once in 3 months and then slowly into once in 6 months. So mainly we look at the BCR, ABL ratio. Once it starts rising, then definitely we have to restart her on TKI, and then we can't wait anymore.
Yeah, so basically you maintain the level below less than 0.01, and do you also do the WBC counts regularly?
So even if we do a CBC, the decision making is based on the BCR, ABL. So the other parameters, they don't really affect our decision making.
This is for the planned pregnancy for a CML patient. But in practice, many times they come with the pregnancy, they complete it, even though we don't advocate pregnancy while on treatment. It's a slightly teratogenic drug is there and metabolic strain is there. But in RCC experience, they say every year 2 or 3 pregnancies are there is not much effect is seen in that.
But I think, I mean, it has been shown that the tyrosine kinase inhibitors, though they don't decrease the ovarian reserve, but they do have an effect, and they say that it can cause abnormalities in the oocyte as well as the sperms, and they also increase the risk of miscarriage. So would you not advise a patient for contraception during that period?
Definitely. So TKIs will affect the pregnancy outcomes.
Yeah.
That is what it mainly affects. So definitely a patient of CML, we would advise them not to get pregnant while they're on TKI. The moment, ideally it should be a planned pregnancy, but the moment the UPT comes positive, the TKI should be stopped. And they should be switched on to something else depending upon what is the stage of the disease and all. But like Sir said, in a country like India, CML is quite common. And when we look at the lower socioeconomic status, patients do not have that understanding of contraceptive and all. And most of the times they turn up at around 8 months. They are on TKI, and at 8 months of gestation, finally they will turn up because they know that, their doctor has told them not to get conceived, but still it has happened. And then they turn up at 8 months and the outcomes are still good only. So the lack of data is there in India where we don't have much data available. But I think the practice suggests that usually, I think 7 out of 10 would have a good outcome even if they're on TK. But definitely, if it's a planned pregnancy, we should stop it.
Yeah. So what are the alternative drugs you give in case she conceives?
So in case she conceives, then ideally in the first trimester, actually none of the drugs are really approved for first trimester. But still, if she's in active disease, then I would like to go for interferon. Obviously, if she conceives in the first trimester, the disease is quite active, I may even give her the option of MTP, whether she can abort, because in case the disease is not going to be controlled and I really need TKI, I don't want to continue the pregnancy. But in case the disease is under some amount of remission and patient really wants to continue the pregnancy, then interferon is one option. Interferons are quite safe in the first, second and third trimester. And once we reach third trimester, TKIs can still be re-challenged at that point of time.
Yes, we already discussed that. So would you advise fertility preservation before you are initiating tyrosine kinase inhibitors, or before you're going for stem cell
So I think in my clinical practice, ideally for young females, I don't advise for fertility preservation because like we know now TFR is possible. So what we tell them is let us go to second generation or third generation TKIs upfront and get 3 to 4 years of very good control. After that, we can go for treatment-free remission period, and at that time, you can plan your pregnancy. For an hematopoietic stem cell transplant, irrespective of the disease, ideally they should be counseled for fertility preservation because after a hematopoietic stem cell transplant, the fertility is definitely affected
Yeah,
and the
because you're
outcomes
going to
are.
give radiotherapy and chemotherapy to the patient.
So, ma'am, that depends actually. There are two types of stem cell transplants, autologous and allogenic. In allogenic also, it is only in the ALL where radiation is given. So in ALL, we give total body radiation and that really affects the fertility outcomes. But ideally for stem cell transplant, all of this should be done. But something that when you talk to more and more hematologists and oncologists, you realize is that all the hematologic malignancies are really emergencies. And when we talk about this fertility preservation all, most of the time the patient is not really bothered about it, or the patient doesn't want to take the chance of waiting for 10 to 15 days before the treatment is initiated. They really want to get on with it. So most of the time when I'm talking to them, 90% of them will tell me, sir, let us not wait for it, let us just go ahead with treatment. We don't want to go ahead with fertility preservation.
And what are the criteria for stopping TKI and then giving them a TKI-free period for conceiving? What are the criteria?
So the real criteria is, like I said, ma'am, at least they should not have changed their line of TKI. So if they were started on one TKI, they should be continuing on that. They should not have changed to a second line TKI. If they are changed to second line TKI, that means the relapse of TFR is higher. So they should be on the same line of TKI from the initiation, at least 4 to 5 years of very good deep molecular remission. And so these two are the major criteria. If they are fulfilling these two, then definitely we can go ahead with the TFR.
Yeah. So you also look at the molecular response and all in these patients?
Definitely. All of the patients, so all CML patients are now looked based on molecular only.
So basically she wanted to try for natural conception when she came to us. So we had stimulated with tamoxifen and she ovulated with a good endometrial lining. So actually I advised her that you can go for your embryo transfer because you have your embryos present. But she said she didn't want to go. And then we treated her with gonadotrophins and she conceived in the third cycle. She's 20 weeks now ongoing pregnancy. So how safe is the treatment-free remission in these patients?
So the safety is basically depend upon the BCR-ABL ratio. If you look at the data available, usually around 50% of patients will relapse within the first 1 year of TFR. That is what has been seen. So that means she has a 50% chance that she may relapse at 1 year of TFR. Then other thing is there is even a risk, there's a small risk, a 5 to 10% risk that somebody who has a chronic phase of leukemia can become an accelerated phase or can become an acute leukemia. Even that is there if the TFR fails. So these two risks have to be clearly explained to the patient and only then we go for a TFR.
So she's been told by her oncologist to do the PCR ABL every 3 months and these are her results. Now she's due for her third test. And her WBC count, but this time her WBC count was on the higher side. So do we do anything for her?
So is that 14.3 or is it 1430?
Sorry, it's 14.30.
14.3, right? So it's 14.3. Definitely, I would still check the BCR-ABL. If it is still in the increasing trend, and if she is now in second trimester of pregnancy,
yeah,
I would definitely ask her to start on interferon.
Okay.
Or she can wait for maybe 1 month, but then the monitoring has to be more close.
Yeah, so now she's due for her PCR also.
So I think in that case, I would like to monitor her monthly. I would increase the frequency of monitoring, just so that I'm sure that she will suddenly not end up with a relapse. That is
because I just saw her now 2 days back, so she just told me that her WBC count has increased, but her oncologist now has told her to every 3 monthly she's doing, so she's going to do that.
Apologies to interrupt, ma'am. We are running short of time.
Yeah. So you want me to end here? No issues.
How many slides, ma'am?
No, it's okay. I mean, I have another 2 cases, so it's fine because if it's already there.
Apologies for the inconvenience.
Sure.
Thank you so much,
Thank you,
Madhuri
ma'am.
ma'am, and all our panelists for an engaging and insightful session.
We don't know anything about oncology. It's a good learning experience for us.
It was such an interactive session.
Relapses,
Yeah.
very often I just did IVF for a patient. She wanted to now try for a pregnancy and she was in remission. And by the time she, we froze the embryos and she wanted to do something, whatever, delay for 2-3 months. And within 3 months, 4 months, she had again relapsed. So now she's wanting to go for surrogacy. Within that
Yes, ma'am. So
short
that is why,
period of
that is
4
why
or
the
5
decision
months.
to give treatment for remission has to be very clear. You can't give to anybody. It has to be given to a patient who has been really compliant for the past 4 to 5 years.
No, she's been very compliant
For
and
the past
everything.
4 to 5 years, she had a very good BCR-ABL values. Like it has to be less than 0.001. It is MR 4.5 raised to 4.5. So somebody like that, we can definitely. But like I said, there's always a 50% chance they will relapse in 1 year. So if they have relapsed, that means the tumor biology is not good and she has to be on treatment. But she can proceed with her pregnancy on the second line treatment as long as she's ready to take the risk.
Decided for surrogacy. So.
Yeah, I think that's a sensible option.
Yeah, so this patient, I should tell her basically every monthly she should get her PCR done.
In case it is rising, so if you check again this time,
Huh.
so right now it was 0.0 I know, after that it has become 0.025.
Yeah,
In case now it has become 0.1, one more decimal has reduced,
Yeah.
then definitely I would like to monitor her every monthly and I will tell her that anytime she has to be started on treatment. Yeah.
Oh, thank you. So I thank all my panelists for excellent discussion.
Thank you, ma'am.
And thank you everybody.
Thank
for
you
being
so
here.
much, Madhuri ma'am, and all our panelists for an engaging and insightful